Berbs, and thank you for inviting me to give this presentation. Let me first try to share my screen. Does this work? Okay.
Yes, I think.
So my talk will be on the rise and fall of disease, on the amazing phenomenon that when we look back in time over the past centuries, and when we study the trajectory of many specific diseases, that we find that a large majority of diseases show a pattern of spectacular rise and then equally spectacular fall. And it's as if human development over the past centuries is accompanied by rising and falling diseases, by diseases rising and falling. And while it's easy to understand that human development is accompanied by declining diseases, that's what we expect, it's less easy to understand that human development is also accompanied or has been accompanied many times by rising diseases. And that's why the subtitle of my talk is "And Other Paradoxes of Progress." These rises and falls of diseases can be seen as a paradox of progress, of human progress over the past centuries. And I think that also applies to COVID-19. I won't speak about COVID-19, but that is also to a certain extent a disease of progress, like many of the diseases that I will talk about during my talk. And as Bert has already made clear to you, I've recently published a book from which most of what I will tell you this evening, this afternoon, will be drawn, a book on the history of population health, rise and fall of disease in Europe. For this book, I've collected a huge amount of data, demographic data, epidemiological data, incidence of diseases, mortality by cause of death, case fatality of diseases to the extent that such long-term data are available, economic data, and digested the medical historical literature on the past 3 centuries. And I've, in that book, described the rise and fall of more than 40 diseases. The cover of the book, as you can see, is from Italy. And I've chosen the cover of this book because it's actually poster from the Italian National Fascist Organization for the struggle against tuberculosis. And it illustrates the important role of political factors in the history of population health in Europe. I won't have much time to talk about that, but when we look at the developments of population health in Europe, it's very easy to see the enormous impact that politics has had on the history of diseases and the history of population health. On my final slide, I will show you the website from which the book can be downloaded free of charge for those of you who would like to know more about the history of population health in Europe. The story of today starts with the rise of life expectancy that I'm sure you are all more or less familiar with. This is a graph that goes back to the 18th century. A country like Sweden already started to collect mortality data around 1750. And what we see here is a broad band of life expectancy curves going upwards from around 35 years, life expectancy at birth, till more than 80 years at the present day. And I've indicated a few more countries in the next slide, some countries from the northwest of Europe, others from the south and from the east. And what we see is that although all countries have had their life expectancy seen increasing. There has been a lot of variation between countries in the timing of this increase in life expectancy, but also variations over time with important setbacks that have occurred. Generally speaking, countries in the south and east of the European subcontinent have started their increase of life expectancy later than countries in the north and west, and also have seen some more serious setbacks. That's particularly true for Russia, indicated here in the red line, which has had enormous setbacks even recently after the fall of the Soviet Union in 1990. This enormous increase of life expectancy at birth has puzzled many researchers who have asked themselves what is the main explanation for this rise of life expectancy. And in epidemiology, one particular theory has become quite prominent, the theory of the epidemiologic transition, which was formulated by Abdul Omran, an Egyptian-American epidemiologist who worked in the 1960s, 1970s in the US, and who proposed that the increase of life expectancy that we saw in the previous slide was basically due to the fact that infectious diseases were exchanged for chronic diseases like circulatory diseases and cancer. And because infectious diseases killed people at a young age, whereas cardiovascular diseases and cancer kill people at older ages, this exchange resulted in a strong increase in life expectancy at birth. And in this epidemiologic transition that Abdul Omran described, he distinguished three specific phases or ages. An age of pestilence and famine, that's the age or the stage preceding the actual transition, a stage dominated by infectious diseases and famine. Then a stage of receding pandemics, reductions in infectious diseases, during which life expectancy increased enormously, and then an age of degenerative and man-made diseases that started around 1970 in the US, according to Abdul Omran, in which mortality is dominated by chronic diseases like cardiovascular disease and cancer. That's the theory of the epidemiologic transition as Abdul Omran has developed it, and I've always found it somewhat strange, the terminology that he used. For example, the use of the term age of degenerative and man-made diseases, which seems to reflect a certain degree of pessimism that he felt, and many more people felt around 1970, when life expectancy appeared to have reached a plateau in many Western countries, not only in Europe, Western Europe, but also in North America. A plateau that seemed to represent the a stage in which no further progress would be possible. As you see, shortly after 1970, and Omran actually published his work in 1971, shortly thereafter, life expectancy started to increase again. And that illustrates some of the problems with the epidemiologic transition theory. I've listed a few of these problems here. There are many more that have been discussed in the literature. For example, it's not so clear when the transition as developed by Omran started, because when we look carefully, large epidemics started to recede long before 1870, when he thought the epidemiologic transition started. Did the transition really end? As I just mentioned, new mortality decline started around 1970. And in recognition of the fact that both before 1870 and after 1970, there were many important changes in the epidemiological situation in North America and in Europe. Many people have proposed to distinguish several different transitions. But as I will show in a moment, there is actually no end in distinguishing different transitions, because diseases seem to rise and fall at many different times without clear cutting points between different stages. And then finally, a more fundamental criticism of Omrand's theory is that he didn't really propose a more fundamental explanation for what happened than this exchange of infectious versus chronic diseases. And in my book, I've tried to address some of these problems by developing a new idea about the epidemiologic transition, which I've boldly labeled Epidemiologic Transition 2.0, in which I distinguish 3 sets of changes, but acknowledging that the distinctions are actually quite blurry. That will be the first part of my presentation. I will then continue by illustrating some of these ideas by talking about the rise and fall of a number of different diseases. I don't have time to go through all the 43 that I've studied. I will talk about 7 or 8, I think. And we see that all these diseases have a pattern of rise and fall. And I will talk about the theoretical implications of that generalized phenomenon. And I will then end my presentation by spending some time on the explanation of these phenomena by comparing 2 authors who have been very influential in our thinking about the long-term trends in population health, Thomas McCune and Samuel Preston, who held completely opposing views of what the main explanation of the increase in life expectancy was. According to McCune, this was an unintentional side effect of economic progress. According to Preston, it was an intended effect of public health and medical care. And I will present you my view on who was right in this discussion, McCune or Preston. So these are the 3 parts of my presentation. I will start by presenting very briefly how I look at these long-term trends in population health. And based on my analysis of these 43 diseases, I think it's possible to distinguish 3 different stages or periods of change. A first period, which I've provisionally labeled the period of health problems of pre-industrial societies, in which population health was dominated by problems like famine, plague, smallpox. The period starting long before 1700, ending around 1870 in Northwestern Europe and in North America, in which these problems of pre-industrial societies declined, partly as a result of precursors of public health, then called medical police or public hygiene, but were exchanged for new health problems, the health problems of industrializing societies. Then in a second stage, these health problems of industrializing societies like infant mortality, intestinal infections, respiratory infections started to decline, partly as a result of investments in public health and in a later stage by improvements in medical care, but were then replaced by the health problems of affluent societies, which started to decline in the third stage, which started in North America, in Western Europe around 1950, with gradual declines of mortality and sometimes also incidence from cardiovascular diseases, some cancers, and a range of different types of injury, again with an important role for public health and medical care. In this third stage, we also see some diseases rising, but it's difficult to bring them on a single label, these diseases that are rising. These include diseases like dementia and Parkinson's disease, but also some new infectious diseases like AIDS and currently COVID-19. So these are the 3 stages that I think could be distinguished. And in order to illustrate that, I've reproduced here the trend of rising life expectancy that you saw before, but I've now added vertical broken lines indicating the border between the three stages: the stage of declining health problems of pre-industrial societies, then the stage of declining health problems of industrializing societies, and finally the third stage of declining health problems of affluent societies. Let me now talk in a little bit more detail about the diseases that characterized these three stages, starting with the first stage, in which we see many health problems of pre-industrial societies declining. And these are the 7 health problems for which I've been able to find long-term data showing whether the development of that particular health problem is characterized by a pattern of rise and fall or not. And as you see, only homicide, which is one of the 7 conditions on this list, is a health problem for which I've not been able to identify a clear pattern of rise and fall. But for all the others, it's very clear from the historical literature and also from the empirical data that others and I have collected, that numbers of deaths have first risen and then fallen. And the timing of these rises and falls is very different. Start of the rise is sometimes very far back in the past, but all these health problems started to fall in the 16th, 17th, 18th centuries in this first phase that I've just mentioned. And let me illustrate 2 of these conditions in a little bit more detail, smallpox and malaria. Smallpox is a disease with a well-known history. It probably started to rise somewhere in the early Middle Ages in Europe as a result of the fact that people started to live more closely together in cities that became larger and larger over time. And in the 17th and 18th centuries, in some cities in which cause of death data were already collected, smallpox accounted for around 10% of all deaths. So this was really a very important disease in these pre-industrial times. But then around the year 1800, vaccination was introduced in Europe as a result of the work of Sir Edward Jenner. And what we see in the countries that already collected national data on causes of death is that around 1800, mortality from smallpox started to decline. And the 2 examples here in this graph are Finland and Sweden. And in addition to these national data, we have data from many regional or municipal areas, for example, from London, which also show that coinciding with the introduction of vaccination, smallpox mortality started to decline precipitously. There were some flare-ups, for example, here around 1870, partly due to the relaxation of vaccination policies, but currently, as you know, smallpox has been eradicated. And to some extent, smallpox is one of those paradoxes of progress. The fact that smallpox arose as an important cause of death is the result of the fact that people started to live together more intensely and in larger numbers. And a similar phenomenon has played a role in many other infectious diseases. The second example that I would like to show is malaria. Not many people are aware of the fact that malaria has been endemic in Europe, even above the Arctic Circle, for many centuries. Malaria is a disease of agriculturalists. It has accompanied the advent of agriculture in many parts of the world, and certainly in Europe. And while quantitative data on malaria are only available starting in the late 19th, early 20th century, we know that in countries like the Netherlands and the United Kingdom, Malaria was much more prevalent in the 19th and in the 18th centuries, and that the disease had already started to decline as a result of the drainage of swamps, and also as a result of the introduction of quinine, the first efficacious drug against this disease, which was already available in the 18th century. But some other countries lagged behind, including countries in the south and in the east of Europe. And in order to show you more clearly what happened in these other countries, I've exchanged the normal y-axis for a logarithmic axis in this alternative slide, where we see that while in Britain, malaria was already almost completely conquered in the first half of the 20th century, that was not at all the case in many countries in the eastern and southern part of Europe, where malaria was only pushed back in the 1940s and 1950s. That can be seen very clearly in Russia or the Soviet Union, but it's also true for Spain and for Italy. I mentioned Italy for the cover of my book. Mussolini was very effective in pushing back malaria in his country in the 1930s and 1940s, and so was Stalin, the communist dictator of the Soviet Union, in the 1930s and 1940s. The Soviet Union had very effective campaigns against several infectious diseases, not only against malaria, as illustrated in this poster from the 1940s from the Soviet Union, but also against typhus, against tuberculosis, and several other infectious diseases. And it's somewhat paradoxical to see that the communist regime in the Soviet Union, on the one hand, saved so many lives due to the effective campaigns against infectious diseases, but on the other hand, killed so many people in the great purges of Stalin of the 1930s and 1940s. Let's move to the second stage, the stage of falling health problems of industrializing societies. And during this stage, many more diseases started to fall, so that I need 2 slides to mention all the diseases for which data on these long-term trends are available. And here are a few of them. For example, cholera, tuberculosis, syphilis, influenza. Let me illustrate 1 or 2, starting with cholera. Cholera is also a disease of which we know its history quite well. It's a clear disease of progress between quotation marks, because it came to Europe as a result of the increase in international trade, which brought the cholera bacillus from Southeast Asia into Europe. It was a very frightening disease. People died in the streets, which was one of the reasons why it was cholera that started the modern public health movement. And cholera arrived in a number of different waves. The first pandemic of cholera did not reach Europe, but the second one did. And so did the third, the fourth, the fifth, and the sixth. And you see here, for a number of European countries, the number of deaths attributed to cholera at the national level in each of these countries. These were huge numbers of deaths in several countries. The second pandemic was very fatal. The third one was. During the third one, John Snow, the famous predecessor of modern epidemiologists, did his studies of the Broad Street pump. During the fourth pandemic, there were the famous studies by William Farr, and as a result of these studies, several countries started to implement sanitation measures in the second half, in the 1860s, 1870s. For example, England and Wales and the Netherlands. And as a result, the fifth pandemic did not cause as many deaths in these countries as the fourth, the third, and the second one had done. But Germany, France, and Spain had delayed implementation of these sanitation measures, and their numbers of deaths started to fall spectacularly only after the fifth pandemic. And as you see in Russia and Italy, there were some further delays which resulted in high numbers of deaths even in the early 20th century from cholera. Nevertheless, public health measures were able to almost eradicate cholera from Europe in the period considered. And the second illustration of diseases that started to fall in this second stage is tuberculosis, another very well studied disease, another disease that can be regarded as a disease of progress in the sense that it accompanied the urbanization of Europe. It rose enormously during the 17th, 18th centuries. In some countries, we can follow this even at the national level. In Sweden, for example, where we see tuberculosis mortality rising until about 1870 and then declining. And we see tuberculosis even rising here in Portugal at a much later stage. But in all these countries, mortality from tuberculosis has started to decline in this second stage, indicated here by the two vertical lines in the graph. As a result of many different actions, including improvements in housing conditions, improvements in working conditions, pasteurization of milk, and several other measures that reduced exposure to tuberculosis infection. In this stage, there were many other diseases that started to decline. I can't go into details for each of them. Puerperal fever are another important example. Rickets, peptic ulcer, appendicitis. And while I will skip infant mortality, which was an important cause of death, declining in this period, I will spend a few words on appendicitis, which is actually something of a puzzle, a disease which started to rise in the early 20th century and then peaked in the 1930s or 1940s in many European countries and started to decline very strongly to reach very low levels again in the second half of the 20th century. And there are actually two theories about the rise of appendicitis. A theory that attributes the rise to a declining intake of dietary fiber, and a theory that attributes the rise of appendicitis to the increase in hygiene, better hygienic habits, which led to an upward shift in the age distribution of infection, and children who get an intestinal infection at a somewhat higher age are more sensitive to develop appendicitis. Each of these theories has something to speak for them, but the decline is probably not related to any of these two factors, to dietary or to hygienic practices, is more likely to be due to the introduction of effective medical measures against appendicitis, the introduction of antibiotics and effective surgical therapies for appendicitis. And then the third stage, the stage in which health problems of affluent societies started to decline. These problems had started to rise since the late 19th century or the first half of the 20th century. But then most of these diseases, like ischemic heart disease, like cerebrovascular disease, like breast cancer, like prostate cancer, started to fall either in incidence and mortality or in mortality only. And one of the most famous examples of this is, of course, ischemic heart disease. It's well known that the development over time of ischemic heart disease has followed a spectacular pattern of rise and fall. In this case, not only of mortality falling, also of incidence falling. And in some European countries, we can actually see this complete trajectory or almost complete trajectory of rise and fall. For example, in England and Wales, we see a clear rise and fall. In Sweden, a clear rise and fall. In the Netherlands, we see a rise and fall, and the peak years differ somewhat between countries, but in most Western European countries, ischemic heart disease mortality has been declining since the 1970s. as you see. In some Eastern European countries, including Russia, the pattern has been rather erratic and heavily influenced, I must say, by political factors. Just as an illustration of the influence of political factors, the decline here is related to Gorbachev's anti-alcohol campaigns, the increase here to the crisis, the economic crisis under Boris Yeltsin, which was then reversed and then came back as an economic crisis. And we see the effects of Putin's efforts to reduce ischemic heart disease mortality in the Soviet Union in this strong downward slope of ischemic heart disease mortality in Russia since around the time that Putin came to power. But apart from political factors, the causes of the rise and fall of ischemic heart disease are, of course, the changes in living conditions, living habits, smoking, dietary habits, physical exercise habits account for the rise of ischemic heart disease mortality, and then the decline is due about half to improvements in lifestyle behaviors and other factors influencing the incidence of disease, and about half to improvements in treatment of the disease. And let me then end this tour along all these different diseases by looking at my final slide of another 7 diseases that started to decline. At least most of them started to decline in this 3rd stage. These include liver cirrhosis, these include road traffic injuries, these include suicide and AIDS. And one of the most intriguing patterns of rise and fall is seen for suicide. I don't think many people are aware of the fact that this is another cause of death that has followed a clear pattern of rise and fall. That's because not many databases go back earlier than the 1950s, but some people have tried to collect data reaching much further back in time, and then you see that suicide actually started to rise in many European countries already in the 18th and early 19th centuries. And on this longer timescale, we also see very clearly that in many countries there has been a pattern of rise and fall. Look at Sweden, where suicide peaked around 1970. Look at Hungary, where it peaked around 1980. And there are many other countries which have shown a pattern of rise and fall. And there has, of course, been a lot of discussion about why suicide has risen so much. And you may be aware of the famous theories by Emil Durkheim, who attributed the rise of suicide in the 19th century to the loss of social connections, of social cohesion in European societies. And while this may have played a role, when we look further back in time, it's clear that suicide already started to increase before the social changes accompanying industrialization and urbanization. And some authors working in this field have argued that the rise of suicide has also its causes in the reduction of barriers to committing suicide as a result of the enlightened thinking, which made suicide, making an end to one's life, more acceptable and took away the taboo on suicide. That may account for the rise of suicide, these 2 factors, but the decline of suicide, the only reasonable explanation that has been proposed is that it has to do with improvements in mental health care, and particularly the increased use of antidepressants. And then finally, and there is a reason for ending with this final example of AIDS. This is no longer medical history. This is almost contemporaneous, of course. AIDS has also been characterized by a strong pattern of rise and fall. And the nice thing about AIDS is that this is the shortest trajectory of rise and fall of all the examples that you've seen, that I've shown, and of all the diseases that I've studied. As you see, and if we take the example of the Netherlands, which is the green broken line here, AIDS mortality started to rise in the 1980s, like it did in the US and in many other Northwestern and North American countries. And after slightly more than 10 years, AIDS mortality already started to decline. And this is the absolute record among the diseases who have had a pattern of rise and fall. And this is, of course, due to the enormous speed with which medical research found the causes of AIDS and with which the practice of medical care and public health has implemented both preventive measures and treatments for AIDS. And of course, this should make us a little bit optimistic when we look at the current COVID epidemic. Hopefully, the COVID-19 epidemic will have an even shorter life than AIDS had, which was already an extremely short life, at least in terms of the main pattern of rise and fall, as we've seen it in many European countries. As you see here again, Eastern Europe lags behind Western Europe, but also in Ukraine, for example, AIDS mortality is already declining. This ends my rather long tour along all these examples of rising and falling diseases. And let me now move to the third part of my presentation, a shorter part focused on the explanation of all these phenomena. And first of all, I'd like to stress again this amazing fact that a large majority of diseases for which long-term trends can be studied have shown such a pattern of rise and fall. Why has this been such a common pattern? And as I said in the beginning, it's easy to understand that human development goes together with falling diseases. That's partly why we try to develop ourselves economically, socially, scientifically. But why should human development also be accompanied by rising diseases? And I think the general conclusion here, I think, should be that these diseases, most of these diseases arose as a side effect of human development, as a side effect, to be more precise, of the pursuit of better living conditions, of adopting agriculture, of living together in big cities, of becoming more affluent. And as a result of the pursuit of better living conditions, the environment in which humans live has changed faster than evolution could cope with. These changes have been occurring at a timescale of decades, of centuries, much faster than our genetic makeup could adapt to. And of course, genetic factors may play a role in determining our sensitivity to these environmental factors, but overall, I think the conclusion should be that environmental factors are the dominant influence on the occurrence of at least most diseases that we've experienced over the past centuries. And then the discussion that I briefly referred to in my introduction, the discussion on why did life expectancy increase so much? And the thinking about this question has been very strongly influenced by two authors. One author, Thomas McEwen, who has become very, very popular in medicine and certainly in public health, who in the mid-1970s published the results of his studies, for example, in a book called The Role of Medicine, in which he analyzed the role of medical care in reducing mortality from infectious diseases and in increasing life expectancy. And to summarize it very briefly, he concluded that neither medical care nor public health were the main factors in declining mortality and increasing life expectancy. He thought that the main explanation was nutrition, an unintended side effect of economic development, which improved the nutritional status of Europeans and thereby reduced mortality from tuberculosis. This idea has been hugely influential, but at the same time that McCune published his work, Samuel Preston, an American demographer who is still alive and active, published his work on the increase in life expectancy, and he reached completely different conclusions on the basis of, well, similarly simple analyses, but somewhat different analyses, in which he showed that while national income, prosperity, economic development, the main factor that Thomas McCune thought was responsible for the increase in life expectancy, while this is indeed an important determinant of life expectancy, when we look at changes over time in the relationship between national income and life expectancy, we see an enormous shift upwards between the 1930s and 1960s. And actually, if we would add, as I've done in some papers, the 1990s and the 2010s, we see that the curve has shifted even further, suggesting that there must be much more than economic development that accounts for this increase in life expectancy. And Preston thought that this was intentional, that this was not an unintended effect of improved living conditions, but an intended effect of what we do in public health and medical care. And based on McCune's and Preston's work, I've tried to develop this ladder of human agency in health improvement. The discussion between Preston and McCune is about the role of human agency. To what extent did we humans ourselves reduce mortality, and to what extent was this intentional or not? And that's not such an easy thing to elaborate. Of course, medical care is entirely intentional. That's human agency reducing mortality in optima forma, and that's number 5 on this ladder. And so is public health. That's entirely intentional. But then there are many other changes in human behavior that we do or that we pursue for reasons that are only indirectly or related to health, or perhaps even completely unrelated to health. And whereas McCune thought that the increase in life expectancy was mainly due to numbers 1, 2, and 3 on this list, Preston thought that it was mainly due to the numbers 4 and 5. That's what they said in the 1970s. And since then, there has been a lot of additional research on what accounts for these declines of mortality from all these specific diseases, and also what accounts for the increase in life expectancy. And I've tried to summarize this in this huge table, in which the columns represent this ladder of human agency in health improvement. The column with all other changes are the numbers 1, 2, and 3 that were popular for McCune, whereas the column public health is number 4 and the column medical care is number 5. And of course, all these other changes, unintentional changes in living conditions, have accounted for some important declines of mortality. But it's also quite clear that public health, and in a later stage, medical care, has made important contributions to declines of mortality. And I've mentioned just a few examples in my presentation. So I think, in conclusion, that the concept of the epidemiological transition as developed by Omran is certainly in need of repair. It's actually been a long drawn out process of superimposed rises and falls of many different health conditions, and it's difficult to distinguish clear stages. I've done my best in distinguishing the 3 stages that I did, but the borders are blurry. This battle of ideas raised by the McCune thesis, I think, has been won by the proponents of human agency, of whom Preston was one of the first. Intentional efforts to reduce mortality have been more important than these side effects of economic or social development. But of course, these intentional forms of human agency have been facilitated by economic, sociocultural, and also by political factors. And I've mentioned a few of the political factors as illustrations of that during my presentation. That brings me to the end of the presentation. For those of you who would like to read more, here is the reference to the book from which most of the materials come. You can download the book for free from the website of the publisher. And some of the other things that I've mentioned, particularly the role of politics in declining mortality and increasing life expectancy, have been described in a few previous papers listed on this slide as well. That brings me to the end of my presentation. Thank you, and I look forward to the discussion.